This week on the BackTable podcast.
In our particular deal, we try to do it based on contribution margins. So if Blake wants to use 5 Asahi wires, those are Blake's wires and he pays for them. So,
Gotcha.
But at the same time, Blake's going to go, okay, I needed those 5 Asahi wires to get this case done. If I don't get this case done, we don't get paid anything, right? Because it's bundled and
Right.
you can't pay that Asahi bill without, or whatever, whatever vendor it is, without crossing that lesion.
Yeah.
So it's a totally different mindset, but at the same time, it encourages the young IRs, young vascular surgeons, and cardiologists of the world to go to that vendor and say, "Hey, man, we need a better deal. I'm tired of paying X for your wire. I want to pay Y, right?" And trust me, these young docs, they can get it done.
Hello, everyone, and welcome to the BackTable Podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com, and also pretty much any podcast platform out there. Medtronic offers a comprehensive portfolio of products for the embolization of the peripheral vasculature. Learn more about the MVP microvascular plug system and Concerto detachable coil system at medtronic.com/embolization. This is Aaron Fritts as your host this week. I'm really excited to bring our guest back on today, vascular surgeon Dr. Jim Melton and interventional radiologist Dr. Blake Parsons from CardioVascular Health Clinic in Oklahoma City. If you didn't get a chance to listen to the episode they were on back in June 2020, they were on episode 69. We talked about pedal access for PAD. We also talked a little bit about, how Jim and Blake met and, how an interventional radiologist and a vascular surgeon and some cardiologists started working together in a complementary manner. And so we're going to get into a little bit about that as well today. So, just real quick intros. Blake, it's been a year since we last spoke to you. I know you're sitting next to your boss, but can you give us an update on how your IR practice has been doing, especially through COVID?
Yeah, I think the practice has been good. COVID has actually, in this outpatient space, probably been pretty good to us. We had actually one of our biggest years. I think a lot of that has to do with patients being scared to go to the hospital, and they're okay with coming to an outpatient center where there's limited patients to be around. And of course, we did COVID testing and all of the typical precautions that were performed at all the hospitals as well. But no, it's been good. The practice has grown, which is what we want. We're continuing to try to perform a lot of CLI interventions and limb loss prevention.
Yeah, I mean, anything that you've added on, and you're the only IR in the practice, right?
Sure. Yeah. So I would say, I do a little bit of everything, but the biggest things that I do here are PAD, venous, both superficial and deep venous intervention, and embolization. We do quite a bit of uterine fibroid. We do, I'd say the prostate artery embolization part of our practice definitely picked up last year. And then we're actually starting to get into doing geniculate artery embolization.
Oh, nice. Just for hemarthrosis?
I do some for hemarthrosis, and then we're currently involved with getting studies set up.
For the OA stuff?
Yep, exactly, as well as post-op pain. And then we also, it's offered on a cash basis as well.
Okay, cool. And then, but what about just real quick, the endo AVF stuff? I know you were starting to do more of that last I saw you.
Yeah, we've done quite a bit. We're back and forth because I have the luxury of having a vascular surgeon in my practice. So I don't have to have it all on me to try to create. And I think there's definitely pluses and minuses of that procedure from what we found. We've done probably 30. It's patient selection. That the procedure itself is very easy. There's a little bit more to the maintenance maturation of it, I believe. And the biggest hindrance, I should say, to it, and I'm not trying to dissuade anyone from doing it, is going to be your dialysis centers, because they've got to be trained. We live in Oklahoma, so I'll just be frank here. There's not many patients that are under or on the lower end of the BMI. So, we're superficializing brachiocephalic fistulas on the regular here. So it's very difficult to be able to do a dual access for a hemodialysis patient at the center when they have a tough time just sticking a large cephalic vein.
Right. Gotcha.
So that's been a little bit of the rate limiting factor for us. But like I said, when I've got a vascular surgeon who can do one in the same amount of time it takes me to do one PERT, it's kind of we've got a lot of options, needless to say.
Gotcha. Well, thanks for catching everybody up on that. I'm going to take it back to Jim. For the uninitiated, Jim, predominantly IR audience, we're starting to grow the vascular surgery audience a little bit, and, definitely, some cardiologists listening as well. But, there's a lot of people out there either already in the OBL, ASC space, or just getting started. And, for the uninitiated, I just wanted to kind of briefly tell the story of your OBL ASC practice, how it started, when you brought on cardiology and IR partners.
Yeah, thanks for having us again. It's a great educational tool, and kudos to your success. It's been great. I listen all the time. So we built, my partner and I, who is an IC, we built a couple of large heart hospitals here in town that were physician owned with a system. And we did that in 2002. And then in about 2013, I started looking around, and what we built became what we left, if that makes any sense. And so it became very heavy on the administration side and inefficient. So we started looking at some models that would be more patient-centric and satisfying for patients, and higher patient satisfaction scores, lower infection rates, and more price, transparency. So that's kind of when it started. And then we left there in 2015 and built what we have, and it's continued to grow. So I think that we started with just an IC and a vascular surgeon, and then, Blake was very forward-thinking very early in his career, and just pretty rare and very impressive, may I say, is to be that entrepreneurial, that young of an age. So I think that it's kudos to him. And since then, interestingly enough, we've had one email that looked identical to his coming out of diagnostic radiology, and he's heading to fellowship. So I think the word's catching on in the IR fields, which is very encouraging. And I see my IR colleagues when I have to go to the hospital, which I still do quite a bit, obviously, unfortunately, but they just all look very unhappy and beat down. And and so I'm so glad that they're seeing there's another way to live life. So that's very encouraging. So from there, we just, we took advantage of the price structure and those kind of things. While we were getting licensed, we used the OBL as a way to finance the endeavor, and then became licensed, and we're able to add, more procedures at that time that were on the CMS pay schedule, which have obviously increased significantly over time.
Okay, cool. Yeah. And just real quick, before we jump into hiring and growing and bringing on partners, just in terms of space, when you first started, did you buy your space or rent? How do you, and can you go through the advantages of either of those?
Yeah, so I think that it depends on where you are, in your career. I think that, if you have a little bit of money and you have the ability to borrow money, it's probably smarter to own the building that you're in. It just adds to your portfolio. I think that, that's what we chose to do, but it doesn't mean you can't rent to own. But I would strongly encourage, if you're going to rent, to have some kind of association with the person who owns the building, that, hey, we're interested in being partners in the building also, in the near future. So most owners that see you as a owner occupied, or even a one owner occupied in a large building, are going to be very open to that.
Yeah. And that's the advice that I've heard from others out there doing, similar things. Mary Constantino, Michael Cummey, I already mentioned those guys. And, Mike Watts was on the show recently talking about his setup. And they all say that, if you can afford to, or make it happen where you're just even borrowing money to own, that owning is probably the best way to go. But again, if you don't want to take on all that, renting and then growing and then buying as you go, I've seen people be successful at that as well. I mentioned these other folks out there who also have found some success in the outpatient setting. And I asked them, I told them I had you guys coming on the show, and I asked them what they really would like to learn about. And everybody said across the board, how do you split the pie? How do you bring on partners? and make it work, especially when, you're an outpatient setting, you're taking global payments and you have you have expenses, and one doctor might use 8 wires, that's a lot. One person might use more resources than another doing a case. How do you then pay them?
Yeah, that's a great question, and one of the the toughest things to learn and teach and kind of get figured out coming out. I think that's the beauty of of a Dr. Parsons or someone young coming from a big institution that can open anything they want or they do just because it's nothing out of their pocket, and then they come
Right.
into a situation where in our particular deal, we try to do it based on contribution margins. So if Blake wants to use 5 Asahi wires, those are Blake's wires and he pays for them. So,
Gotcha.
but at the same time, Blake's going to go, okay, I needed those 5 Asahi wires to get this case done. If I don't get this case done, we don't get paid anything, right? Because it's bundled and
Right.
you can't pay that Asahi bill without, or whatever, whatever vendor it is, without crossing that lesion.
Yeah.
So it's a totally different mindset, but at the same time, it encourages the young IRs, young vascular surgeons, and cardiologists of the world to that go to that vendor and say, "Hey, man, we need a better deal.
Yeah.
I'm tired of paying X for your wire. I want to pay Y, right?" And trust me, these young docs, they can get it done. They have connections, and just to be frank, I mean, we've changed vendors where I never thought we would change vendors, and pricing where it's a very sweet spot because of some of the younger docs in our practice and the relationship. So every product you pull off the shelf is directed towards you.
Gotcha.
And so you come up with that case, and if it's a 20K case and you pull 7K, it's off of that. And if you pull 3K, it's off of that. And then that margin is yours too. Now, we try to come, when they're first come out, we obviously give them, the number, whatever they want. We usually give it to them, salary. And then if everything works out and they like the area and they like the space, and it's hardly ever that they don't like the space. We've never had anyone come and go. Once you start working in something like this, it's pretty awesome. So I think that once they get here and say, yeah, I want to live in Oklahoma City, and that's good, and they've made whatever number they want to make coming out of fellowship, making nothing, then we try to get them on a contribution margin track where, they could double second, third year, their salary easy. Because at the end of the day, the founding 2 guys, we're not here to make money off any of our partners. And I think at the end of the day, we do put some back because we have to have some for capital for the business and stuff like that. But we try to give them as close to their contribution margin as we possibly can.
Yeah, that sounds like a great model, because you leave it to the individual, and whatever, it comes out of their bottom line if they're being wasteful, and yeah, that's interesting.
If they want a Mont Blanc pin, they can buy it.
Right.
Now Blake, he steals pins, so if that tells you anything about him. So,
hey Blake, I wanted to get your input on that model and how, because you and I know people that are come out more recently and have seen things that don't work out, jobs that don't work out. Do you have any input on how it's worked for you versus what you've seen out there?
Well, yeah, I mean, first off, I've been extremely lucky in this venture from the get-go. A, that I found it, and B, that I was fortunate enough to work with Jim and Dwayne, who he mentioned helped founded the company, and that they really have. I mean, I tell you, I heard nothing but this is never going to work from other IRs that have kind of tried this. So I'll be frank with you, most of them had told me this is never going to work. They're just going to try to steal what you do and then push you out and move forward. But I had trust in these guys, maybe if that was stupid or not at the beginning, and they've done nothing but prove to me that they've been good partners. So that being said, he's exactly what he's told you is exactly right. I mean, I came in obviously as an IR and fresh out of training. I mean, I'm from the area, but still, it's I didn't have any patient basis, right? So
yeah,
you're going to have a minimum of 2 years of building a practice. You've got you've got to develop those relationships, but B, as everyone listening knows, no one knows what the hell an IR doctor is outside of the hospital. I mean, they just don't.
Yeah.
So there's a lot of education involved And so they took that time. I mean, they took a big risk on me and paying me a good salary to be able to take a chance that this was going to work out and develop, because we didn't really know. We've got 3 specialists here that all have some crossover, and but it all worked out. So they stuck with me, and then exactly what he told you. Once you get to where now I'm making more than what they're paying me, then that's when just like you said, it crosses over to, it's kind of an eat what you kill, right? So
Yeah.
it is exactly how he mentioned on how many wires, because I use different stuff than he does in some cases. It all comes down, just like you said, if I need to use 18 wires to get the case done, well, you got to do what you got to do. And it's not so much to get the case done because you need to make money, right? That's not what we're here for. It all comes back to the beginning, as you need to be able to get the case done to help your patient out. And that's the bottom line to all of this, is it still is patient first. It doesn't, there's a big, people are like, oh, they're in the outpatient space, all they care about is making money.
Right.
And that's not the case. It really is our goal, and our mission here is to provide a different level of care for our patients in a different space. And so that's what you got to do. If that means eating out of your own pocket on your reimbursement, it doesn't matter. You got to be okay with that. So, but yeah, in the bottom line, quarterly or however you divvy it up, we go through and we know cost, not only your supplies, but we know pretty much to the T what it costs, just because you got more than just what you open in the case. You've got keeping the lights on. You've got staff that's holding pressure outside for your access. There's a lot people doing laundry for you. I mean, you've got all these things, and these are all things you got to think of in this space when you see these large global payments like, oh, these guys are getting rich. Well, there's a lot of money going back out the door from all the things you have to keep the lights on. They don't just make these numbers up, that they're all of why they give us these global payments. They're because you've got a lot of overhead that you have to deal with.
Yeah. And along those same lines, since we're talking about staff and employees, that was the other big question that came up, is a lot of having your own practice is management, people management, hiring, firing. How do you determine whether it be now or in a growth, if you're in a growth phase, and everybody always likes to think they're in a growth phase, is how do you determine what employees to hire and when? And, who do you put in charge of hiring for your practice? We can start with that and we move on from there.
That person that does that's extremely important in the structure. I think that charge person in the surgery center, at least in our place, is just she's not replaceable.
Right.
So at the end of the day, we don't have a hard time hiring the best of the best, because look what we're giving them. We're paying them more than they're making at the big boxes. They have no call. And the only thing that we've ever had issues with is, well, my annual salary is going to go down a little bit because I take all this call. And I go, well, that's a life decision. I'm paying you more per hour. You just have to make that decision. But that doesn't come up much either, because people, and then we just go hire the cream of the cream. Blake and I, and I have 2 more vascular surgeons coming on, one in June and one in January. And so we know who's good right at the hospitals. And so we'll pick them, and we'll cherry pick them off. So
yeah, that's what I attempted to do, was to try, reaching out to techs and nurses that I knew were good. It was just hard to, the whole salary thing, they couldn't get over that. And I guess if they don't have experience in the outpatient setting and how nice it is to work 8 to 5 or 8 to 6 versus 7 to whenever with call, they're just looking at the number, the salary. And so that was the challenge I found in getting people to come to the outpatient setting from the inpatient setting, is it was kind of risky. It was an unknown there. It sounds like you get a similar kind of feedback, but ultimately they probably hear from their peers that, hey, this is a great job, right?
That's correct. I think, at first it was harder because they, your competitors, are all putting in their brain that we're not going to make it and all those kind of things. So, but now that the stability is there, we've had no problem getting like really high end employees.
Yeah. And do you guys have PAs and nurse practitioners?
We do have them in the practice, but they don't do much in the lab.
Okay. Gotcha. So that like in hospital or in the clinic, you mean?
Yes. So we have a lot of rural clinics. So they're out doing that. They're out marketing. They're
Gotcha.
out doing rural clinics and finding critical limb ischemia and helping those places that really need that help for amputation prevention.
And at what point did you guys bring them on where you thought, okay, that we need a PA or a nurse practitioner? There's this sort of, we don't quite need another doctor. We don't quite, we need somebody above a nurse. At what point was there a decision point there that you can remember?
Yeah, I think the volume that my partner and I had was, we needed probably from day one, but we just kind of held out. And I think that at the end of the day, our rural clinics are up to about 11 now, and they're all over Oklahoma. So we fly to them, we drive to them, and so we have a lot of clinics that we can put NPs and PAs in that do an incredible job at taking great care of patients and preventing cardiac events and catastrophic peripheral events.
Yeah, and those rural patients, how do you get them to your OBL or ASC to get the procedures done?
No, we fly out private and to bring them back. No, I'm just kidding. We just set them up.
Some transport.
Get their appointments. That they'll basically make the decisions in the rural community, or it'll be Blake and I, because we go out there too. We don't just send. So we go to our clinics and we just tell them that this kind of high end technology and stuff has to be done in the cities, and they're more than willing to come. They're just happy that they didn't have to come for just a doctor's visit to the city and not know what they were going to get, all that. So it's a really good model. It's been our model for 20 years. Even the heart hospital that we built, that's why they're so successful also.
Gotcha. And most of your recruiting is local. You're not trying to recruit techs and nurses nationwide or anything like that. Most of them you're getting locally.
That's correct. Yeah. I mean, we have other, we have some more ASCs going up in other cities and stuff. So we kind of use the same model to try to find those people in those venues also.
This is a question for kind of both of you guys, but how do you split up time specifically, like time in the lab for each partner? You say you kind of have this individual eat what you kill, but if somebody's just getting as many cases as they can, the other person's kind of falling behind. And then they find, well, there's no time in the lab. How do I even get in the lab? I mean, how do you handle those kinds of issues?
And so we'll triage cases, as far as, move some to the hospital. That's one way. And then also there'll be a time when we have a state approved additional 10,000 feet on the ASC. We're ready to pull the trigger on any time. So,
oh, gotcha.
That'll be ready to go whenever volume dictates.
Yeah. And then how about the amount of time that everybody has to spend marketing? I mean, you mentioned the PAs and nurse practitioners take some of that off, but a lot of times, especially a junior partner that comes in, you want to get that face out there so they're meeting referring docs. How do you, is there a formula for that you guys have? Is it just kind of any downtime?
Yeah. So everybody needs to come follow Blake Parsons around for 4 weeks. He is the master at marketing. So that's about all I can say. He's one of the best partners I've ever had. I tell you, he's done a lot of his own. I mean, we obviously have a name and a brand, but he just goes out and beats the doors down and has no problem walking in any office at any time. And he's done an incredible job at that. I'll let him speak to that.
Yeah, Blake, what's your pearls on the marketing side?
Oh man, it's just shaking hands and kissing babies. I mean, to be honest, it's just kind of going back to what I mentioned earlier on. You've got 2 years of not being very busy, right? So if I didn't have a case or I was done with the clinic, I just got in my car and went around. And the biggest thing was just to go out and meet potential refers, your other community doctors. For us, obviously, just like any city, there's going to be big networks and they own a lot of the primary care referral bases, but we really make it a point to stay in contact and form good relationships with our other independent docs. And so, there's a lot of going out, explaining to them education. We do a lot of breakfasts. No one wants to do dinners anymore. It's just the day and age. Everyone works hard, wants to go home, see their family. So we do a lot of breakfasts, a lot of lunches, education, and it's just being there for your referring docs. I mean, we're all married to our cell phones these days, and that's what I tell them. I mean, they all have my cell phone number. They ever need a patient they're worried about, and they just call me and I see them the same day, next day. But that's just what you have to do. You got to be ready to answer your phone at any time, be ready to call them, help them out any way you can, because they want to establish a relationship. A lot of their problems with quote unquote specialists from primary care and the big systems is that they don't feel respected a lot of times, right? They just
Right.
refer it and they don't know what happens. They don't get any follow up. And so they feel like they're kind of left out of the loop. So, I always tell them, and they're the most important part of this equation. They're the ones on the front lines
Yeah.
fighting the fight. We're just here to try to help them out. So, that's a lot of it. Is just getting out there face to face.
Yeah. How do you guys decide on imaging and PAC systems, EMR stuff? Like, how does that?
It's a good question, because we're doing it right now.
Yeah. I mean, is that like do you guys take a vote on it as a group, or, is there a few people that lead that decision?
Yeah. So we have usually monthly meetings with all the providers and staff that are involved, and we sit down and, so we're currently changing our EMR. We had one EMR system for the past 4 or 5 years, and it was time to make a change. And so, literally we would sit down and in the evenings, and you'll be here till late at night and going over different, PowerPoint presentations by these companies. And then it's trying to find one. When you have a multidisciplinary specialty, you got to find one that helps everybody, right? So
Yeah.
it's a lot of sitting down and talking through it and going out. And the same thing with PACS. And there's obviously a money component to it as well. But you got to have something that's going to make your life easy as well. There's no point in buying the cheapest car on the lot if it's not going to get you to work.
Yeah. And again, you guys are buying over leasing, right?
Correct.
Is there a grace period where you can try something? Do you try to negotiate that kind of stuff, or you just go for it?
Exactly. Same with companies for your wires and catheters. We do the
Right.
same thing on that end. It's just trying to negotiate contracts and making sure that the company has a little skin in the game as well as we do.
Yeah, right. Exactly. How much support are you guys getting from companies in terms of helping to bring patients in? It seems like a common complaint I'm hearing from colleagues around the country is like the rep will come in, they'll introduce themselves, they'll say, hey, whatever I can do to help. And then, it seems like it used to be the reps were a lot more involved with helping you get those referrals, and it's less these days. Do you guys have any, have you experienced that at all? Probably not, because you guys are high volume.
Yeah, I think that, they're kind of limited on what they can put in print, stuff like that nowadays. So I think that they're really on edge on any of that stuff. I think that if you find a good rep and a good vendor, they'll definitely, if they were in the past, if they were in the pharmaceutical business, that's a nice fit because they know all the GPs, and so they can go out and say, man, you got to see what these guys are doing,
Right.
And so they'll help you market a little bit. Sure.
Yeah.
And
You
then
think
any
it's more- it's a-
dinners, like the virtual stuff has helped a lot with, the vendors buying minutes for virtual meetings. We'll do
Oh.
live cases and, Avail, shooting anybody here as far as their company, but Avail's got a good product out that basically very, very high-end optics in the operating room that can do a live case. The vendor, it's zero cost for the physician or the facility. You just have their device in your facility, and it's free. And then vendor, whoever your vendor is that day, they pay for the minutes of the case. So that's pretty helpful. They'll do that anytime you want. And they do it to their sales force too, because they want people to learn pedal, or they want people to learn how to do, what Blake does or what you do. And so they're very open to that, especially given the past 13 or 14 months we've had. Yeah.
Yeah. That's very cool. I haven't heard of that company. It's called Avail, you said?
Yes.
All right. Yeah, that's super innovative, and like you said, really helps with teaching and learning, especially when, have you guys been, I was there right before COVID, but have you guys been doing as many, on-site teaching sessions, or has that been limited as well?
Yeah, it's been really limited because the companies, they won't let their rep fly, or, they won't let them get out of the closet. So I think that the Avail system's been very helpful.
Yeah, helpful. Yeah, cool. Really, one of the last questions I had for you, Jim, was as a group, how often do you guys talk about growth goals and vision? Are these quarterly meetings? Do you guys have corporate quarterly meetings or yearly meetings? What amount of time is spent on the here and now versus where we want to be? Can you talk on that a little bit?
Yeah, so it's really would be ideal if we could like shut down for Thursday, Friday, Saturday, Sunday, and go somewhere really cool and have a think tank, right?
Yeah.
But we may do it anyway. I don't know, but but it's hard to do. We try to do it. I think that at the end of the day, most successful places, hybrid especially, is very high on the list. OBL's only still good on the list, but the long-term viability of those probably not as attractive. But are we going to get a capitalization in this deal, and are we going to do something with some capital and get growth that way, where we do acquisition and bring in like groups and like-minded people and just grow this thing, not only in the Midwest, but nationally, So those are things that we think big. And so I think that at the end of the day, and when you're doing that, I think it's the most important thing is to find, usually not a strategic, probably a private equity buy that has not large payments on the front end, but leaves a ton of equity on the back end for that second, third bite of the apple for your partners. Because I've got 30-year-old partners here and I've got to take care of them. You have to do that in order to build a strong group and to acquire physicians that you want, because if you're just in it to get a front end large buy on a capitalization event or whatever, then it's just not going to work for the younger guys. So you've got to do that in a special way. And, we're focused on that for sure. Because I think we're excited about taking this model wherever it'll go. Yeah.
And you mentioned something really important is finding like-minded people that have a similar vision. And you guys are, a good sized group. And I guess any tips for even whether you're starting out by yourself or two people or three people or, an organization, that whole, finding like-minded people, is there any magic to screening those kinds of people out, or is it just, a combination of luck, I guess?
Yeah, there definitely is a model on finding the right recipe on who. I can tell you with a pretty high percentage of who's going to be successful based on geography, their age, and their current practice.
Yeah, that's interesting.
Yeah.
How's Dallas look?
Dallas is awesome.
Okay, well, that's pretty much all I had for you guys. Any closing remarks or advice for people out there who might be struggling with their OBL right now?
I think that, again, we're always here to help. I think that at the end of the day, we hope to be someone that, that can help, in a model that can be successful, and people, be able to say, hey, we can do that too, And I think at the end of the day, you have to look at that geographic area. You have to look at the partners, their practice, and you have to step in that cold water a little bit. And I think at the end of the day, we're going to see a gigantic migration of this model outside of the hospital.
Yeah, I totally agree. I was talking to a fellow the other day who's joining a vascular surgeon in 2 IRs in the Orange County area. And it sounds like he's walking into a great practice, a nice collaborative practice between the three of them. And he's super excited about it. He's straight out of training, just like Blake. Blake, anything from you, man?
No, we just always appreciate it, as always, having you have us on BackTable. It's been great. Look forward to seeing it out there and the any kind of replies and information. And like you said, we're always open. You can always hit us on Twitter or wherever. If any questions, call us anytime. We're always available.
Awesome. Well, thank you to our listeners for tuning in. There will be show notes available for this episode shortly. But until next time, thank you.